पर सामने विचारों कि वो मतलब तो दूसरों को से favorite of course free gas in peritoneum we can call it pneumoperitoneum and pneumoperitoneum leads मतलब free gas in peritoneum causes gas is liberated from confined space and that cause leads to which condition? Peritonitis, inflammation or infection of peritoneal cavity. Okay, so minimum gas required to show gas on the diaphragm 1 ml. If it is less than that amount, free gas on the diaphragm may not be visible. Other signs can be visible. Gas can be inside the peritoneal cavity. There are other signs. It is not like that. If patient said free gas in the diaphragm is not visible, so it is not pneumoperitoneum. It is not like that. Because what happens before radiological signs develop, signs and symptoms develops. So clinical examination, history, complaint. Signs and symptoms develop first, then radiological signs. So never rely on radiological signs. Presence of sign is indicative. The absence of sign is not suggestive to absence of condition. So clinical exam. So that all radiological reports which are angle is correlate. False positive or false negative. So never rely total one. Never rely on total on your clinical signs because you require radiological investigations. But never rely totally on absence of radiological sign. Clinical acumen. History taking examples. Patient जो बात करिए से feeling आवे से put hand on abdomen feeling आवे intuition कहते हैं. Clinical intuition it cannot be replaced by anything. Operation robot का विकास है, पर operation पची care कौन करता है? Complication develop थी robot cannot identify. Clinician can identify. That is a complication reacts. Time reacts पर patient will suffer. कौन नहीं कर सकता? Clinical acumen. हमारी generation हजी. I don't know about next generation. In your generation, even who is better clinician, better surgeon may not be better clinician. Darker than fundal gas shadow. So if it is free gas in the diaphragm and fundal gas shadow is also visible, then usually one is the crescent shape of the free gas, thin line, and it is usually darker than fundal gas shadow. What is the most common cause of free gas in the diaphragm? Pneumoperitoneum. Perforation of lower viscous. There are two types of viscera in abdomen, solid viscera and hollow viscous. So perforation of the hollow viscous. Luckily or unluckily in abdomen, all hollow viscous contains gas. The hollow viscous here they are gas. Perforation except GB. When in GB, what will happen? Gas-burning organism infection and our infection by gas types. So in case of GB perforation, there may not be free gas but intense peritonitis. Free gas might be. So perforation, appendical perforation, gas may not be there. Even though it is a perforation of hollow viscous, there may not be gas. But yes, if it is gas, it is under pressure and there will be huge gas shadow. If there is gas-forming organism, anaerobic infection. Because when in bowel, anaerobes are there. Duodenal perforation is a common cause. Peptic perforation is the most common cause. So usually it is the first part of duodenum or it is antrum. Pre-pylorus or post-pylorus. So pre and post-pyloric area is called as peptic area because pepsin is secreted there. Pepsin secreting mucosa. And these are the cause of hyperacidity and causes consolidation. These are the areas of pepsin secreting area. Also that it is called as peptic area. So that it is called as peptic perforation. Perforation of the first part of the duodenum and perforation. It is already ulcer, then there is perforation. Perforation is a complication of duodenal ulcer, peptic ulcer. So once anterior duo perforates, duo मतलब duodenal ulcer. If it is anterior placed duodenal ulcer, it perforates. If posterior duodenal ulcer, it bleeds. Bleeds मतलब posterior wall of duodenum, anterior wall. In both areas also it is called the kissing ulcer. So anterior perforates, posterior bleeds. Why? Posterior ulcers, yes, gastroduodenal artery. Because ulceration is inflammation. It erodes. Gradually what causes it erodes neurovascular due to inflammation. And erosion of vessel is the common cause of spontaneous bleeding of vessel. Erosion due to malignancy, erosion due to infection and inflammation. It's a common cause. One of the causes causes spontaneous bleeding, spontaneous rupture of vessel. So posterior duodenal also bleed. Most common cause of hematolysis. What is the most common cause of hematolysis? No. Ulcer. Ulcer. Peptic ulcer. It is most common cause. When ulcer bleeds, upper GI bleeding will always followed by simultaneously with melena. When there is upper GI bleed and there is melena, it is source of bleeding is upper GI. Hematolysis with melena. Sometimes it is hematolysis is relative. First presentation is melena, black color stool. If it is black color stool, source of bleeding is upper GI. If it is faint blood or clotted blood, source is lower GI. Upper GI, lower GI differentiation क्या है? Ligament of Reis. क्या differentiation? Gas on the diaphragm seen in 70% of duodenal ulcer perforation. It is not 100%. It is peptic perforation, that doesn't mean free gas should be there. Absence of free gas doesn't rule out peptic perforation. Okay? Clinical symptoms are important. Sometimes what happens, there is a perforation, free gas नहीं दिख रहा है, there is no free gas. So what we used to do, we put rice tube and inject the air. 150 to 200 cc air is injected. And after 10 minutes, after 10 to 15 minutes, we advise patient to keep in sitting position or standing position, and then we put the exhale, do exhale. And then there will be, if peptic perforation is there, there will be free gas in the diaphragm. Patient is moribund, patient not able to stand, then lateral decubitus swing. So many times what happens, there is no free gas. What is another way? Lateral decubitus exhale. Then we can see gas under the lateral wall of abdomen. Under the wall of abdomen. So that we can see free gas. Post-laboratory pneumoperitoneum takes 7 to 14 days to disappear. In Jilton, gas get absorbed fast. That's what it means. So one of the cause of free gas in the diaphragm is post-operative patient. So laparotomy, laparoscopy, whatever we did, up to 7 to 14 days gas remains inside. If you advise X-ray, there will be free gas. Free gas white. So that you must remember. Immediately after coming out or free gas out, that doesn't mean again export to room. That is not like that. So it remains, it gets absorbed and it takes time. Okay? So one of the question when you identify this free gas in the diaphragm, Christian saved free gas in the diaphragm. That is suggestive of pneumoperitoneum. And causes of pneumoperitoneum, perforation of the oviviscus, and post-laparoscopy, post-operative open or laparoscopy. Then, બીજા કેમ બે કામ પછી Chillarity is sign, but actually it is not free gas in the diaphragm, it is gas in the diaphragm. Investigation, Rubin's test, hysterosalpingiography, Rubin's test. So what happens? Dye with air is injected per vaginum, gas will in the intraperitoneal region through fibula, ત્યારે 20 મિનિટ ઇન્ડિયામાંથી ગેસ આવશે. સો પોસ્ટ રૂબિન સ્ટેજ histossalpingography. So post ruben stage there is a free gas under diaphragm. These are asymptomatic. These are all pneumoperitoneum are not symptomatic. What is symptomatic? Peritonitis. Peritonitis is symptomatic. All pneumoperitoneum are not symptomatic. So these are the causes of free gas under diaphragm or pneumoperitoneum. And what you can, so you are over viscous perforation, then you can say common septic perforation, then aortic perforation, then sometimes it is anti-perforation, bowel perforation, large perforation, bowel perforation, gallbladder perforation, appendical perforation, urinary bladder perforation, traumatic, uterine perforation. So this can cause, these are all hollow viscous. So that can cause pneumoperitoneum. So once pneumoperitoneum, that is peritonitis. Viva can go on again presentation, how patient will present, and what is the treatment. So you just do exploratory laparotomy and suturing of perforation if required, and if it is not possible, then resection responses of types of peritonitis: primary peritonitis, secondary peritonitis, and tertiary peritonitis. What is primary peritonitis? So one of the cause of leakage in the diaphragm is the primary peritonitis, infection by gas-forming organism. Peritonitis by gas-forming organism. The gas is already formed but with bacteria. And that causes gas in the diaphragm without any perforation. That is again another cause of pneumoperitoneum. So primary peritonitis is spontaneous peritonitis. It is called a spontaneous bacterial peritonitis. So infection with gas-forming organism. Most common in young female. Most common in young female because there is a infection. PID is there. There is an infection of gas-forming organism, ascending infection. From vagina it goes to uterus and fallopian tube, and organism is peritoneum. So it is ascending infection. And surprisingly, it is a gram-positive organism because it is ascending infection. So this is common in young female, spontaneous and pediatric patient, but spontaneous bacterial peritonitis. It is primary peritonitis without any perforation. Secondary peritonitis, peritonitis due to perforation or trauma. Some cause is there, is infected and injured the peritoneum. It is called as secondary peritonitis. Tertiary peritonitis, we operated patient, we treated patient, resection of stomach suturing has been done, and post-operative suture is postponed. And again peritonitis, again content is coming through, but it will not symptomatic. You cannot judge clinically. The post-operative patient is already abdominal pain, tenderness will be there. So difficult suture, tertiary peritonitis. So that you must able to define things in bio. Okay, other signs of pneumoperitoneum. One is the classical, is free gas under diaphragm. Okay. Now other signs are cupola sign, regular sign, inverted V sign, football sign, triangle sign. उपमा छे होता है, बरोबर? Because how to see in X-ray, X-ray में भी देखा, and how it happens. So this is X-ray of cupola sign. Okay, free gas under diaphragm. And this free gas under diaphragm only can be appeared when patient is in standing position. Patient standing position में क्या जाना? इधर तो gas will diffuse. नहीं होगा. So when it happens, so cupola signs can be visible when, by chance or by mistake, first X-ray is done in supine position. Abdominal X-ray, supine position. Alright. So what is cupola sign? Gas is settled down at highest point of diaphragm, at the hiatus. Diaphragm highest posterior, highest level at the hiatus. From where esophagus and aorta and everything is coming out. This is the highest level of diaphragm, where gas is settled. When patient in supine position, what is highest level? Hiatus. Here gas settled person, and we can see against vertebra in level 1, the central place That is a gas shadow. આમાં જુઓ તમે. There is a central plus gas shadow. There are Christian gas shadows there, but there is a central gas shadow again. It will not appear in all cases. દેખાય છે જ્યાં ટુકડા સાઇન લખ્યું છે ને એની ઉપર જ છે. એકદમ ગ્રે જેવો છે. This gas shadow is usually not visible because all it acts as a standing position. જો supine position માં કરશું ને તો આ gas આવશે. That is called as cupola sign. One is called as cupola. What is cupola? It is an architectural term referring to a small dome, in particular a small dome crowning a roof of a tower. The word derives from a Latin word for little cup. ठंडा प्रदेशों में मकान जीवा मिले for sunlight. So this kind of architectural dome, it is called as cupola. Here, same related gas is visible, highest level, so that it is called as cupola. See, gas shadow is not highest level. અહીંયા જુઓ તમે. It is gas shadow convex vertical, centrally placed. It is not highest level. The gas is settled at the highest level of diaphragm. સમજાય છે? Visible નથી. જ્યારે patient supine position માં હોય ત્યારે hiatus is the highest level of diaphragm, where gas is detected. It is illusion. Illusion છે. On a supine chest abdominal radiograph, the gas rises and accumulates underneath the central dominant diaphragm of the midline. It is seen as lucency overlying the lower thoracic vertebral bodies. The superior border is well defined by the inferior border. Inferior margin is not. Regular sign. The appearance of prominent wall due to presence of pneumonia. Gas must be on the one side of bowel. Bowel છે તો gas હંમેશા અંદર હોવો જોઈએ. So in reference to bowel wall, gas will be only one side of the bowel wall. When gas is visible on both sides of bowel wall, bowel wall ની બે બાજુ gas દેખાય. That is regular sign. સમજાય છે? So when you see, it is difficult because it appears in minimum amount of gas and then there is more gas in the diaphragm. Accidentally supine X-ray the standing table. But you look at it carefully in X-ray, many a time it is not appreciable. But then we can identify because if gas is settled there, perforation is nearby. Perforation fusion can so gas is on both sides of the bowel wall. Gas હંમેશા એક બાજુ હોવો જોઈએ, બે બાજુ છે. Then it is regular sign. है ना? White line, central white line surrounding by both side, gray line. અહીંયા જુઓ તમે. There is a arrow છે ત્યાં એક white line છે. It is contrast basically. If both side gas is there, then the dominant bowel wall is visible. Otherwise bowel wall will not visible. બે બાજુ black હશે, dominant wall આવશે. That is striking feature. आगे पकड़ जाना. This is the isolated segment, है ना? क्रॉप करने का रूल से. आपको एक्सरे ना बोलो. हमारे पास आपका एक्सरे हो, तो आपका एक्सरे ना करो. ये तो क्रॉप करने का है. Invert can be falciform ligament or single sign, football sign, triangular sign. So when gas is liberated, triangle sign. Triangle sign is the loop. Gas entrapped in loop. Gas is entrapped in loop. તમે એક bowel loop imagine કરો. One bowel loop is there, okay? Loop છે. So quadrant area triangle થઈ જશે. both bowel loop એક loop પકડીએ તો quadrant area triangle હશે. Mesenteric area. Gas is entrapped there. So now it is triangle sign. So gas is entrapped in the loop of the bowel. It will show just like George, triangle sign in the bowel. Beautiful triangle sign. That is sign. That can be site of perforation. And brain for Mukesh as well. So it can be post-operative. Here football sign. When it appears, football sign. when there is peritonitis. Fluid check, over free fluid in peritoneum. Patient in supine position. Okay? So what will happen? Bowel will float. Bowel will float over fluid. So it will accumulate in central area. When patient acquires supine position with free fluid, bowel will be centrally placed. And fluid is dispersed in whole abdomen. So gas is also dispersed in whole abdomen if gas is there. So see here black arrows. Black arrow shows what? Grey is delineation, grey color. Whole peritoneum grey color. So gas is distributed through whole peritoneum. Supine position must go. Pink gas share, but it is distributed in whole abdominal wall and peritoneum. Gas bowel is settled in central, floating bowel, gas filled bowel. If this kind of picture is there, it is football sign. Just like American football. Football version but it is very rare thing because we always do not perform supine exercise. Jab supine exercise we have the science. CT scan finding inverted V or falciform ligament or C. It is nothing but falciform ligament is triangular shape. It is fatty. So gas is settled over both sides. So black shadow and white line. तो inverted V-shaped gas shadow તમને જોવા મળશે. So that is called as inverted V sign. But it can be appeared in CT scan mainly. So these are the signs for pneumoperitoneum. Pseudo-pneumoperitoneum, that is chirality sign. Okay, it is called as pseudo-pneumoperitoneum. Subpulmonary pneumothorax, again pseudo-pneumoperitoneum. It is not pneumoperitoneum, but it looks like gas in the diaphragm. That is subpulmonary pneumothorax. Chilaiditi syndrome, in presence of Chilaiditi sign. What is Chilaiditi sign? Transposition of transverse colon between liver and right diaphragm. This is sign, Chilaiditi sign. Colon, transverse colon is situated between, it slips and it is in between right diaphragm and liver surface, usually now. So it is transposition of transverse colon between liver and under surface of diaphragm. Abdominal pain, torsion of transverse colon becomes torsion, shortness of breath. Chilaiditi syndrome. If these symptoms are there, you have to think that it can be Chilaiditi syndrome. Abdominal pain function, shortness of breath function. And you advise X-ray, there is a transposition of transverse colon. So how do you differentiate? It is not crescent shape. It is not crescent shape. It is not intense black. It is confined gas. Outside gas, bowel gas oil, so black color is there because now it is pure gas. Inside the bowel wall is also there. So black color is also there. So intense black nothing. And it is not crescent shape. Luckily, if it is present, you can identify ostration. Ostration agar se, it is colon. So subphrenic abscess, again infection with gas forming organism, we can have visible free gas on the diaphragm, gas shot on the diaphragm, but it is not free gas. Subdiaphragmatic fat or momentum fat on the diaphragm, sometimes it gives gray shadow. We may misinterpret as a pneumoperitoneum, but there are no sign symptoms. Abdominal pain is tenderness, grinding, rigidity. Usually when it is peritonitis, it is rigidity. Generalized rigidity. Rigidity is always generalized. Okay? So when there is pneumoperitoneum, causes of pneumoperitoneum, operation with prison, how you will manage? You need to explore the laparotomy after resuscitation. After resuscitation, because usually patients are in septic shock. And stabilizing the patient. After stabilizing, you do explore the laparotomy, identify perforated area, and suturing the perforation. If it is not possible, sometimes resection and hemostasis. After the perforation. The detail now, you will chance. Biliary three-plane X-ray, very few signs. So gallstones sometimes visible in X-ray. Or usually gallstones are radiolutions. They do not visualize, but 10% are radio opaque. So it is one of the differential diagnoses of radio opacity in right hypochondrial region. One of the differential diagnoses is radio opaque gallstones. Radio opaque is on the right of the vertebra below rib cage. In lateral X-ray, in front of the vertebra, kidney stone overlaps the vertebra. So same thing can happen in right pelvic stone, renal pelvic stone. How do you differentiate? So just advise lateral X-ray. If opacity is overshadowing vertebra, then it is kidney stone. Opacity is anterior to vertebra, these are gallbladder stone. Okay? So GB stone, if it is GB stone, see this picture. As I said, it is not picture of any. It is picture of cholecystography. Cholecystography in what picture? So this kind of stone can be visible in cholecystography. See, X-ray में के CT में identify नहीं था. These signs, single sign versus band sign. Triradiate and biradiate. If it is biradiate, it is single. And triradiate is versus band sign. Can you appreciate picture? Triradiate and biradiate. Beautiful picture. Multiple gallstones with radio opaque line. Differential diagnosis of radio opaque shadowing right hypochondrial region. As in lower belly also, whatever. So it is chopping of a guy in the exam also. Like a walking up with the kidney stone, gallstone, calcified tip of the polyp, flavonoid, periodicity model, vessel, vein, artery, pancreatic stones, foreign body, thick calcified lymph node, renal tuberculosis, calcification, it is also called as nephrocalcinosis, RCC, renal cell carcinoma and breast carcinoma, calcification, microcalcifications are primary very significant. If you find macrocalcification, no. If you find microcalcification, it is diagnosed. Either we remove kidney or keep it for long. Patient ने क्या सब patients को कैसे करना हो? Adrenal tumor calcification, calcified adrenal tumor, tendinomatous normal, calcification of atheroma of aorta, sometimes aorta, calcified wall of aorta can be visible. Calcified lesion in liver highlighted cyst. And both of them are right side, radio opacity, देखा है. 5-6 याद रखो दो सर. These are the fact. All are very different. This is only radio opaque shadow. इतना मत बोलो. Radio opaque shadow करो. The shape of the radio opaque shadow, type of the radio opaque shadow, size of the radio opaque shadow, and region suggest your disorder. Pneumonia, what is pneumonia? Air in biliary. Air in biliary. What is Wiggler's triad? Wiggler's triad. It is Wiggler's sign nothing. Wiggler's triad. Goldstone Williams. Goldstone Williams. Triad का क्या वस्तु है? कैसे वस्तु है? Goldstone doyers, પછી airfoot level, intestinal obstruction છે, goldstone ileus છે, and pneumonia. And ત્રણ વસ્તુ હોય તો શું હોય? Wiggler's triad. So it can be post ERCP, it can be after biliary surgery, and ascending cholangitis, again gas forming organism. And in this condition, કોઈ પણ જગ્યા ઓપન કરો એટલે એર પર જોવાની. So that is pneumonia. Sometimes it is visible on X-ray. This condition matches. X-ray acute pancreatitis. Radiological signs in acute pancreatitis. Gastrosarcoma, sentinel lobe, colon cutoff sign, duodenal ileus, and renal venosa. Renal halo. It is difficult to catch up. Even if you try to see, it is not possible or patient. All sign is not possible in same patient. And evaporation may not have same signs. So first is gasless abdomen. Sentinel lubricant, one of the model group of gas-filled development is used. Usually it is duodenum. Duodenum is distended when it is a acute temperature because nearby organ is duodenum. So it is affected. If the inflammation by mesenchyma of the model becomes angry, unabundant, and it becomes distended. The sentinel lubricant duodenal first part of distended first part of duodenum, sometimes the gastric dilatation from oil. If nearby ileum is there, it can again becomes silent. So gasless abdomen, there is a fluid, so gas will be normal. Gasless abdomen. Fluid supervenes, then gas is not visible. Pancreatic fluid collection. Post pancreatitis most common collection क्या हो? Pancreatic fluid collection. ये एक वेनोट्रॉन. First collect where lesser cell. Second collect where retroperitoneum. And third peritoneum. So it is pancreatic fluid collection. So retroperitoneal fluid collection one of the causes necrotizing pancreatitis. When there is a fluid collection in retroperitoneum, what happens? Only fluid is visible. Gas नहीं देता है. So gasless abdomen. Sentinel colon cut-off sign due to fluid collection in retroperitoneum. So what happens? Transverse colon is intraperitoneum and descending colon is retroperitoneum. So what happens? Only transverse colon is visible and near splenic flexure, no colon. It is called as colon cut-off sign. Descending colon may decline. That position, that is colon cut-off sign. Duodenal ileus and renal halo sign. Again, retroperitoneal collection. Retroperitoneal fluid collection is there. So there is a kidney, perinephric space and paranephric space. Remember, perinephric space and paranephric. Fluid is collected in paranephric space. There is a perinephric space. That is a fascia. And there is a kidney. So you will have, once fluid is collected, what will happen? It gives contrast and fascia may have kidney visible. Kidney visible just. So see here E renal sign. Kidney becomes visible. So how you can, sometimes you don't try to see it. If it is visible, it's okay. You don't try it. But yes, if sign is visible, it is visible now, it signifies thing. Many times in acute abdomen, it is very, in immediate condition, very difficult to judge the peptic perforation है, peritonitis है, pancreatitis. It's very difficult to judge clinically. Ultrasonography sometimes will not help us. If it is pancreatitis, we should not open it. If it is peritonitis, we must open it. तो double-edged sword જેવું છે. One of this sign is positive, it will have. Oh, it is pancreatitis. And then we do not open. Acute fulminating pancreatitis and you open up to the patient will die. Because patient is at margin. Compensatory phase model. Inflammation chair, inflammatory SIRS. Cytokine surge and our open. It is life-threatening. It is not life-saving. Peritonitis was open narrow again life-threatening. So clinical judgment is important. Sometimes it is not always 1 plus 1 2. Upon OIG series, after advanced talks, after practice of CT scan, now it is not practice. Only barium solo we are using. Barium is nearly obsolete. Not the significance of that. Even barium minimum. Because we have excellent CT scan, 3D construction, virtual colonoscopy. There is no place of this now investigation. Sometimes in exam, we put the plate. Then we prefer putting plate of barium study rather than CT scan. As you used to not होता. CT scans are only little bit difficult to identify. So we put plates of barium so that you must allow. So what is upper GI series? Barium solo, barium will follow through, small bowel enterocolits. Barium lower GI series, barium minima, this is lower GI series. And so what is the purpose? It is just opacifying the lumen with barium so that it will give you detail of mucosa and space occupying lesion or even obstructive lesion. You can identify tumors also in inflammatory conditions, polyps, hernias, and strictures by these studies. Barium solar is again, it is not for organic causes, functional cause. Functional condition of esophagus. It can be cast in only bariums, not CT scan and not endoscopy, only bariums. So still it's value, it has value. Dye is injected, dye is ingested. Double contrast, single contrast, double contrast. Single contrast, patient is taking barium sulfate, not barium phosphate. Patient is ingesting barium sulfate in a glass. It is the thick paste. It just ingests, now it is passing. In real time, picture is taking. Okay? So in IITB, real time, barium is passing and how it is passing, what kind of luminal condition, how it contracts. Is there any narrowing? Is there any hyperperistaltic activity? Some signs are there. So how it contracts, how is passing, what time is taking, is there any stagnation, is there any perforation or is there any leakage that we can see. So barium is passing, so it can catch functional condition of esophagus. Functional condition मतलब diffuse esophageal spasm, ecalacecalia, spastic esophagus, sometimes diverticular. This can be catched on barium solar. Patient is symptomatic, endoscopy normal, CT scan normal. What will you do? What will you do? Barium solar will catch it. So that is important. So barium is open, patient is ingested barium. Now what will happen? We give effervescent fluid, ENO, which liberates carbon dioxide. Effervescent fluid, air जरूरी. So now ingest ENO. It washed the luminal barium. Luminal barium will wash. Now what happens? It cannot wash barium stick to glucosa. Barium adherent to paste. It is pasted on glucosa. It will not remove by this effervescent fluid. Now what will happen? The mucosal lining will be visible. Lumen will clear, but lining is visible. So mucosal detail, ulcerated, growth is there, ulcerated growth, polyfoil growth, strictures. Mucosal detail can be visible. So it is called double contrast barium scholar. Double contrast barium anemia. What is that? First is dye, then gas. How gas will be introduced to rectum? Per rectum. We have to inject gas. Flatus tube. We just put flatus tube and introduce gas. Force tube, promptly. And then it will just push the barium and mucosa will be irrigated. Barium anemia, okay, there is colonoscopy and colon is there. Virtual colonoscopy. Deficogram, again it is a function. Deficogram, patient is a chronic constipation. We cannot identify things. So just give the inject the dye with anemia and then ask patient to do defecation. And what is the movement, how the eye is passing. So sometimes it is inertia, colonic inertia. Sometimes it is dyssynergism between colonic constriction and pelvic floor. When it is called as pelvic floor dyssynergism. Doing synergism for usually. Pelvic floor contract high and then colon move high. So that must happen. If it is a dyssynergism, there is a constipation. Okay? So how we can identify functional disorder? Barium sulfate is called a positive contrast agent. Barium sulfate suspension for different parts of GI tract. Barium sonoma 250% of picture. If you want to remember this, it's okay. But it is around information. What is the purpose of using barium? The barium thickness will be different. All investigations are not doing with the same concentration. Double contrast Upper GI CO2 with upper oxygen like lower GI wherein room or pump through rectal tube. Water soluble contrast media is called as positive contrast agent. Gastrographin, meglumine, glycosides. These are positive contrast agent. Water soluble contrast media. Overall molecule is called as neutral contrast agent. So positive contrast agent, neutral contrast. What is neutral contrast agent? It is overall molecule. Okay. In CT scan you give. These are some features of barium solo. Red tail sign, echinacea cardia. Just terminal narrow angle of the esophagus. Line is passing, but there is a thin line. Contracted that distal esophageal sphincter. And proximal dilatation of esophagus. In any condition, in any blood, echinacea cardia identify the treatment also. What is the treatment of echinacea cardia? That this is the again echinacea cardia, huge ampulla. You just see dilatation of esophagus. Distance between two wide arrow. So much dilated esophagus. It is called as ampulla of esophagus, and that is the feature in echinacea cardia. Burdick sign. Again, echinacea cardia. Ample core periods. It is a growth in esophagus and growth in esophagus. It is circumferential growth. Circumferential growth makes the lumen narrow. So, but when you see in two dimension, it will look like apple core. It is just narrowing the lumen. Okay. So this is again narrowing the lumen, and echinacea cardia is narrowing the lumen. What is the difference between two? It is spatial occupying lesion or mucosal lesion. So in echinacea cardia there is thin narrow line, smooth narrow line, smooth line for mucosal. Here irregular mucosal line. Here shouldering is visible. What is shouldering? Shouldering. Thin line is there, regular line, and again there is a irregularity. This is called a shouldering. That will be malignancy, not in echinacea cardia. Smooth tapering is a benign condition. Irregular tapering, irregular narrowing, it is feature of malignancy. So mucosal regularity. Suppose some mucosal, some multiple polyposis, then there will be irregular mucosa. Multiple ulceration, then there will be irregular mucosa. So mucosal lining is important. Any irregularity in mucosal lining, that will give you feature of ulceration, polyps or malignancy. Smooth sign, diffuse esophageal spasm. Multiple contractions are there. There is no epiparistalsis. So patient is a dysphagia, retrostomach pain. Multiple contraction plus a propulsive apnea. It is not propulsive. So there is no functional peristalsis. That causes dysphagia, retrostomach chest pain. Spasmodic. That spasm causes pain. Fistula. Water soluble contrast is given. So whenever we suspect fistula, we do not give it. And it causes intense mediastinitis, inflammation. We give water soluble. Just this is a picture of patient who just die and it goes through fistula in tracheal bronchial in one space. These are medium male follow-through. Medium male follow-through for what? Small bowel and large bowel. Small bowel up to IC junction and siphon. Medium solo is up to duodenum. Medium solo for esophagus, stomach, and duodenum. For GU, DU, and hiatus hernia. That was very specific. Medium solo for GU, DU, and hiatus hernia. Gastric ulcer, duodenum ulcer, and hiatus hernia. Even hiatus hernia can be visible very nicely in medium solo. Sometimes not in endoscopy or CT scan. Yes, endoscopy can identify it, but best is CT scan or medium solo. So So here you can see urinary cap. Just after entering, general and first part of urinary. That is called as urinary cap, and that is also menstrual sign. Here what happens? Bile is passed through stomach. Now our stomach wall is delimited with bile. Bile is already passed through stomach because it is in small bowel. The classification of small bowel, and stomach is empty. Here again, this small bowel mucosal detail is error. This error sometimes we can interpret as a small bowel diverticula. Diverticula is a mechanism. This is again a chronic gastritis, hourglass deformity. In stomach, it will become in stomach. Most of the sign is pyloric stenosis, dilated stomach. Claw sign, immunosusception, claw sign. So, inoculum, outer tube. What is the layer point? Immunosusception, there is a layer point. This layer point is the etiology of immunosusception. So it can be tumor, it can be polyp. Mucous diverticulum can work as a layer point. It pulls the bowel. It pulls the bowel. Bowel will be inside. So this is a real photography like size of retrosternal colon. So in corrosive stricture we do surgery colonic interposition. Colon is used as a conduit between mouth and stomach. So after 14 days we advise first very slow. If it is passing through colon and stomach, no leak identified, then we advise patient to take orally. So here you can identify retrosternal colon. Usually it is not retrosternal, okay? So with prostration, thin line of dye is passing through retrosternal to stomach. Here you can beautifully see. Some barium means or CT sign or Fox error. CT scan में आप देखा है, वीडियो में. Inverted umbrella sign or Fishner sign. It's just what happens in eosical box. Structure narrow, fibrous, terminal ileum with restricted eosical valve, widened, open, fibrous eosical valve with fibrous shrunken cecum and pulled up cecum. Fibrosis and the pulled up. So these are the features of eosical box. Variant one CT में कहीं पे देखा है. So how it looks like inverted umbrella sign and Fishner signs. It is nothing but it is pulled up fibrous structure with widened open fibrous eosical valve. First in narrowing cecum, again contracted fibrous cecum look like bursting sign. String sign and stalling sign. What is string sign? Persistent narrow stem of barium in the distal region. This is static sign. Cecum thin, very low. Because it is narrow, fibrous, terminal ileum. Dye is passing. This dye is passing fast because now there is no contraction. It tube shape. Narrow tube. Once reach dye there, fast rapidity. So rapidity of action is Stalling sign. Same change here. Only one is the functional, another is the static. Again, beta minima and terminal ileum and cecum. You can identify. Again, transverse colon apple defect, that is transverse colon malignancy. This is complete picture of erythema. Dye is passed through rectum, sigmoid, descending colon, transverse colon, ascending colon, and terminal ileum. Sometimes it reaches up to terminal ileum. Here you can see eosical junction. And wash portions are visible in colon. This is distal leukogram. When there is a colostomy or stoma, any stoma, temporary stoma, we plan to close it. Before that we advise distal leukogram. Routine surgery. All stoma closure is preceded by distal leukogram. What is purpose?
Patency છે કામ
Distal patterns. પછી distal patterns. પછી sphincter, sphincter functioning. It is dysfunctional for up to 1 month to 3 months. काम नहीं करते, so it becomes patulous, temporarily non-functioning. So if it is non-functioning, then you go to prison, there will be a problem. So before that, you have to make it functioning. The sphincter assessment is very important before doing stomach closure. And when you close stomach, તમારો શોર્ટ કેસ મોબાઈલમાં આવશે, પણ આવશે. When you close stomach, so when patient is necessary, patient is gaining weight, and underlying disease is cured. We check for with histologram, distal vacancy, and functioning sphincter, small sphincter. If everything is okay, then we do stomach closure. What is the ideal time? Can be 6 weeks to 3 months. બરાબર? 6 weeks. 6 weeks to 3 months. સર્જરીમાં કોઈપણ ડ્યુરેશન પૂછે ખબર ના પડે સ્કૂલમાં 6 weeks. પણ યુઝલી રાઈટ 2 મહિના. So બચ્ચો પેદા થાય આફ્ટર બર્થ 2 મહિના રેક્ટલ મૂવમેન્ટ બહાર ન નીકળે. આ 2 મહિના ક્યાંથી આવવું પડે? 6 weeks are very 6 weeks are healing period. So અઠવાડિયા શું છે? કોઈ જાતનો ટ્રોમા થાય ને તો કેટલી રાહ જોવાની? 6 weeks. ધીરજ રાખવાની. 6 અઠવાડિયામાં તો રસ્તો મળી જ જાય. 6 અઠવાડિયા સર્વાઈવ કરવાનું છે. રસ્તો મળી જશે. હીલિંગ occurs after 6 weeks. Fibrosis occurs after 6 months. 6 મહિના રાહ જો તો નેરોઈંગ થઈ જાય. It becomes permanent. Okay? Fruit stomach is a distal vacancy and containment. Hartmann's pouch. It is a procedure, surgical procedure. Okay? So whenever there is a rectal malignancy, rectal pathology, patient is old age, patient is moribund, patient can't sustain major procedure, long duration procedure. So this is damage control procedure. Rectal perforation, rectal malignancy. Okay? What is treatment of rectal malignancy? Surgery is resection. Resection नहीं करेंगे तो peritonitis. In presence of peritonitis, we can't dissecting, we can suture. Should not. We can't do the name. Patient will die. The patient is not optimized. Malignancy in surgery में मेरा patient optimized. So that what we will do? Do laparotomy. Operation मर गई. So if bowel is very, the malignancy is there, bowel is in bad shape, we just dissect the section, we bring out proximal lobe as an stoma, and distal opening we close it. One. This is called the Hartmann's process. In some radiological marker we place chlorine, the blue color. So when we expert, we can identify the area. So this is Hartmann's procedure. So after Hartmann's procedure, we always bleeding animal, called leg. And this is the distal closed loop. હવે આપણે કાઢવાનું છે. Second procedure is dissection. After investigations, if patient require neoadjuvant therapy, after completion of neoadjuvant, we do dissection. So Hartmann procedure is a damage control procedure, very useful procedure. Decision making is important. બધું કાઢીને કોઈ નહીં. Okay. Percutaneous transhepatic cholangiography. PTC. PTP is percutaneous transhepatic biliary drainage. This is investigative cholangiography. We just cannulate the hepatic duct through parenchyma, liver parenchyma, transcutaneous, and we inject that. And then we can see what I wrote hepatobiliary treatment. Biliary drainage मतलब it won't stand. And we provide, if it is stand, it is intraparenchyma. But sometimes it is not possible to cannulate. So we put the drain from duct to outside. That is external drainage. Internal drainage is a stand placement. External drainage मतलब it is placed, is brought out to skin. Now bile is drained outside. So PTBD is external drainage. It can be internal or it can be external. So clad skin tumor. What is clad skin tumor? Malignancy tumor at the confluence of hepatic duct. At the confluence of hepatic duct. That is a clad skin tumor. It is basically cholangiocarcinoma. ERCP, endoscopic retrograde cholangiopancreatopathy. It is very classical diagnostic as well as therapeutic procedure. Advantage of ERCP or MRCP is it is simultaneously therapeutic. We can have biopsy, we can have cerebrohemophilia, we can put stent. So indications, reasons in or distal biliary, CVD stone, worms, foreign body, CVD stricture, mass, obstructive jaundice, obstructive jaundice. Due to this reason and reasons, we do ERCP and we identify the reason, we can take biopsy and we can provide biliary drainage. So that is the purpose. So it can be ERCP with, can be associated with US, endoscopic ultrasonography. Okay, through ERCP scope, we can do US, endoscopic ultrasonography. It is best investigation to judge peri-regional area, local area, nearby lymph nodes, and type of the lesion. It is best investigation with the CT scan. Okay. So here you can see feeling defect dilated CVD, intrahepatic biliary, distal and narrow CVD, side view endoscope. Sometimes it is pancreatic duct is cannulated, we can have pancreatic duct also. तो बन्य पण देखा है. Cannulation क्या करना पड़ेगा? If it is only cannulation of ampoule of water, both can be visible. But isolated cannulation of CVD only. CVD and intrahepatic can be visible. T-tube cholangiography, postpone. Previously it was routine practice when we do CVD exploration, removal of the stone and placement of T-tube. So T-tube is removed after T-tube cholangiography. Just inject the dye and we see dye is passing in the duodenum without any filling defect. And filling defect nothing, and then dye is passing in the duodenum. Here as you can see, dilated CVD is there, but dye is passing in duodenum. So there is no obstruction, distal obstruction. Again to check distal obstruction. And then we can remove T-tube. Okay, we can remove. How will you remove T-tube? Covers T-tube. Just pull it, catch it. Pull it. Pressure up. Suppose we pull it, we remove it. That's not possible. Bile must come in through it. Opening the set. Bile can now. Use it. Bile will not come. Can do. Physics. Rule of fluid. Fluid में खासियत सुनो. Easy passage में रहे तो आप लोग नहीं जाए. Straight. Fluid goes always straight. तो straight obstruction में तो side में जाए. If distal passage is here, even though lateral path is there, it will not come. Fluid में speed up यहाँ से it will not go to lateral. So that is the important thing. So distal pattern is not there, then fluid will come through this opening. Opening will be closed within few days. So polycystictomy with CVD exploration due to placement or management of CVD stone with calculus polycystitis. This is peritoneal hydrated cells. We have a picture. That is our patient. This is from Surat. So here there is a classification of radiological classification of hydrated cells. Ultrasonography, CT, MRI. So this is basically 3A, water lily appearance. Water lily appearance. Honeycomb appearance. Water C2. C3A, and C3B. That was basically water system, solid region, solid area, and later on calcification. So how we can classify? This is classified. This is basically detached root capsule from water system. That is water lily appearance. This will not. This sign will not appear in abscess. We have to differentiate from clear fluid collection and abscess. Some congenital anomaly, these are not rare, So anorectal malformation, this is the most common pediatric anomaly in pediatric surgery. Anorectal malformation, most common anomaly. Still patient are coming. Anorectal malformation. So ectopic anal opening or absence of anal opening. Basically, rectum is opening at the abdominal side or not open. And kevai atresia. So kevai atresia. Distal end is closed. It is not open. If it is open and abdominal side, that is fistula. Abdominal side. You may find fistula. So anorectal malformation can be of two types, with fistula, without fistula. Okay? So what is significance of invertogram? Invertogram is a very important thing. It is not emergency. Wait for 24 to 48 hours. 24 घंटे राह जाओ. But invertogram is compulsory before doing any management. So it is initial original condition it shows us. So after 24 hours, we do what invertogram is nothing but patient is inverted. Patient is inverted and only X-ray. It is plain X-ray. It is not diastole. It is plain X-ray. Patient is inverted and X-ray is done. And see uppermost level of gas shadow. Because gas goes up. Gas upper jasa. So now clinically there is no anal opening. So now atresia end and so atresia end क्या अटके इसको कई varieties high level से low level so gas shadow uppermost limit of gas shadow we have to identify where it is and then it signifies level of anorectal malformation high level low level where level importance of clinically as of there are three levels high intermediate and low. Practically, there are two levels, high level and low level. It is decided by PC line, pure oxygen line. So we can see in X-ray pubic bone and pubic and coccyx, it line low. So pure oxygen line. The gas is in invertogram. In invertogram, gas is above PC line. It is low variety. Gas is lower than PC line. That is high variety. मतलब atresia is high level, atresia is low level. If atresia is low level, we can do single step surgery. Just pull it and we can do angioplasty. यहाँ sphincter काम करता है. Pelvic floor is very well developed and sphincter is functioning. बरोबर in low variety. In high variety it is not guaranteed. So high variety is difficult. So in high variety sometimes it is given in 3 stages. But nowadays all anorectal malformation is done in single stage. बरोबर? અત્યારના જમાના પ્રમાણે there is no stage single stage surgery. Expertise is available, advance is available. So pelvic floor muscle identify થશે. They just bring that rectal loop atresia, atresic rectum through the pelvic floor opening, the fix at the anal canal. So it may be necessary to wait until the bowel is 24 hours old. Before rectal gas appears, false positive for high variety. So for rectal gas is stable नहीं जो invertogram कराए नहीं हो. That will cause give false positive for high variety. Still it is not released at the lowest portion. Then we have done invertogram. False positive for high variety. Even though it is low, it will give high variety. Levator muscles contracted, false positive for low. बच्चों लोग ऐसे. हृदय का सुन कैसे pelvic floor levator contract થશે. એ contraction થી even though it is high and it will go below. False positive for low variety. એટલે જવાબ બરોબર. Meconium takes 24 hours to appear in fistula. False positive for absent fistula. ये पहला जो તમે કરાવશો તો fistula appear નહીં થાય. So we what stamp it? It is without fistula. It is only atresia. It is again dangerous. Most important thing is that nowadays CT scan is available. We do surgery after CT scan only. CT scan not over 20 years. What is the value of invertogram? Original condition. Sometimes invertogram में एक low condition there is chronic agenesis. Colon change.